Thanks. I will invite Dr. Ashish Lall to speak on intravitreal injections, how anterior segment surgeons can add it to their practice.
For intravitreal injections, you should have a good grasp on OCT and fundus photography, and you should be able to diagnose the disease so that you know when the fluid is going up and when it is going down and when you can give injections. Dr. Tinku has very nicely explained the OCT, so you have to try and see all the diseases and make an algorithm of all the diseases as to how you need to treat them. So as anterior segment surgeons, cataract, and cataract we are doing. But if we know how to interpret OCT and we have a fundus photography, this can help us in our diagnosis and treatment. These are very common ailments we see in our day-to-day practice. The availability of posterior segment surgeon is questionable at times. So technique is simple, easy to administer, good money, and wow results. Now, intravitreal injections are used usually in these three conditions. One is the vascular diseases like CRVO, BRVO, or any vascular leakage in macula. Choroidal diseases like IPCV or CNVM, and emergency situations like endophthalmitis. I'll be showing you the technique of this. Now, before that, you need to have a good history, good consent, good diagnosis. They are single patient trials like Razumab, Eccentrix, Osiva, or Eylea, or multiple patient trial like Avastin. So I'm just showing you the step-by-step technique. You need to open this. The injection comes like this. So once the injection is opened, you have to take out the injection. 0.05 ml is what we need to inject. Once we've taken it out, we remove the air bubble. And this is how we do. We put a betadine drop, measure 3.5 mm. This is the video taken from outside. And what I want to say is that your needle should be directed into the core of the eye. You need not see the inside of the needle, and you can even ask your assistant to just inject as you keep the syringe stable. Once it is done, you remove the syringe and just try and put the conjunctiva back. This is the surgeon view. Again, I would like to say that this is 3.5 mm. Just mark it with betadine. Just, you can see here, we are just going inside, directed into the center, and we can see the flow of this is how you need to put the conjunctiva back. We need to see whether there is any vitreous wick coming out of that, that hole. In case it is there, we can cut it. You can see here again. Sometimes there can be a subconjunctival hemorrhage. You need not worry about it. You should tell the patient there and then there can be some redness in the eye, which the patient should not worry. You can see here there's a thing. Now there is one more injection, that is Ozurdex injection for chronic CMEs, chronic diabetic macular edemas. Now this is very important. 3.5 mm. If it is a pseudophakic eye, you need not worry too much about 3.5 or 3 mm, but if it is a phakic eye, your direction has to be very good and right into the center. As you can see here, we are injecting this Ozurdex. Once we've done this. Now, I had a very interesting patient who visited to me about 15-20 days back, and an anterior segment surgeon who did it for the first time, Ozurdex injection, did something like this. During the injection, the Ozurdex went into the lens. And now I was worried whether it is a PCR or is it from the side. Though when I was looking at the slit lamp, it appeared that there is no PCR, but probably from the side, the Ozurdex has come inside. And I was prepared with vitrectomy and everything, but however, I was lucky that everything went on very smoothly. I'll just show you this we are removing the cataractous lens, and you just see this. Now the Ozurdex bullet has gone inside. I was planning to remove it, but then I shoved it inside the vitreous cavity because the patient was a diabetic, and that was the indication for using it, and the surgery went fine. So we have various indications like CRVO with CME, and now this patient got Resumab. You can see that the OCT clearly shows decrease in fluid. What we need to see is the fluid, whether it is intraretinal, subretinal, or sub-RPE, that the fluid should decrease. Then we can repeat it. Diabetic macular edema, you can see here they respond quite well. Now you need to know when you have to repeat it. So after every 4 to 6 weeks, you need to again do an OCT, see whether there is fluid or not. And this is very disease specific. For all diseases, there are different algorithms that you need to have in mind so that you can tell the patient accordingly. Again, this is okay. So learn the indications, make algorithms, disease specific, when to inject, when not to inject. And now a last video for people. Sometimes we have endophthalmitis. We need to know the basic steps as to how to inject the antibiotics. This is a 2-port vitrectomy with valve cannulas. My anterior segment surgeon is only doing it. You can see I have put the 2 trocars. Now I'm putting the infusion cannula. Now looking inside the eye just to see the opening. First, I'm taking out the undiluted sample. Then I start the vitrectomy, take out a dilute sample. Now, these 2 things are very, very important because that will aid us in the diagnosis and the treatment further up. Now, I'm doing an AC wash. And once I've done this, I just go inside. Now, core vitrectomy is nothing. You go inside and do vitrectomy for 3-4 minutes, just like this. Your job will be done. You will have ample of space. And now I'm giving the injections. The injections you need to know which injections are required. And so you can see here that just by 2-port vitrectomy, we have done a core vitrectomy as well. We've taken a vitreous for the biopsy, and we have not even given any injections. So this is something that all anterior segment surgeons should know. So intravitreal injections are like cataract surgery. We all should know the technique, the indications, and obviously how to follow these patients. Thank you.
Dr. Lall, very good videos. One point, do you check after would you advise them to check the hand movements after the injection so that there's no CRAO from increased volume and IOP?
Ma'am, I usually don't do this, but what I do is that I just check the pressure. And the pressure should be okay. With one injection, usually I've never seen that the pressure goes so high. But for like endophthalmitis, I never give injections, 3 injections into the eye, just because of this pressure. So that is why I do, for all my endos, I just put these 2 ports, go inside, do a little bit of core vitrectomy, have some space, and then give injections.
Okay, but safer side, I would suggest that check the vision in the injected eye. At least they should be able to see the light or your hands. If there is no light perception or hand perception, it could be very dangerous. Next, the patient may come with CRAO, which cannot be reversed, that vision loss. Not in my own cases, but I've seen patients like that. Especially in glaucoma patients, would you suggest a paracentesis first if the disc is already very bad? Would you like to do that?
Ma'am, that can be done. That is a good
yeah, so on glaucoma patients, we can advise them to take a Diamox on the day of surgery or use their regular drops. But if it's a very severely compromised disc, they may not be able to tolerate even that small period of high pressure. So it's better to do a paracentesis and then inject.
And you need to know the volume of injection. It is actually 0.05 ml, not even 0.1 ml. So for glaucoma patients, you need to be more accurate. For brolucizumab, like patients which can be harmed because of more volume, there you should be more careful.
Yeah. And once you've done the paracentesis, it's important to make sure that the paracentesis is not leaking. I've seen end off happening through that small paracentesis also. So if you can avoid paracentesis in normal patients, it's fine. But in glaucoma patients, yes, paracentesis can be done.
But even post-injection, if they can't see the light, then you have to immediately do a paracentesis.
Yes, yes.
And they start seeing immediately.
True, true.